Hello there. Welcome, everybody. It makes me really happy today to welcome you all to our webinar on Chapter 6 of the Canadian Women's Heart Health Alliance Atlas. And this is on the sex and gender-specific cardiovascular diagnosis and treatment of women. Just a few housekeeping notes before we get started. Please use the chat function to notify the presenters and moderators if you're having any technical difficulties. We would like you to enter questions. There will be an active question and answer period at the end of the webinar. And if you can put your questions in the question box, there's a Q&A function at the bottom of your screen. And if you can enter the questions in there at any time during the webinar, that would be great. And we will address them at the end. To ensure that your sound is working properly, please check your audio settings by clicking your test speaker and microphone. And there'll also be live polling questions throughout the webinar, and answering these polls are anonymous and optional. In the question session, I forgot to mention that because of the public nature of this platform, we ask that you keep your questions general in nature, and if you have a more specific question, personal question, we recommend you contact your healthcare provider. And I'd like to turn to my co-moderator, Dr. Colleen Norris. I forgot to introduce myself. I'm Sharon Mulvey, and I am here at Dalhousie University, Halifax, Nova Scotia. And Colleen is my co-moderator, and she is in Edmonton, Alberta, and she will do the land acknowledgement for us today.
Thanks so much, Sharon, and welcome everybody to another webinar on our In her book, Breaking Sweetgrass, Indigenous Wisdom, Scientific Knowledge, and the Teaching of Plants, Dr. Robin Wall-Kimmerer reflects on the meaning of land to Indigenous people and rights. In the settler's mind, land was property, real estate, capital, or natural resources. But to our people, it was everything. Identity, the connection to our ancestors, the home of our non-human kinfolk, our pharmacy, our library, the sources of all that sustained us. Our lands were where our responsibility to the world was enacted. Sacred ground, it belongs to itself. It was a gift, not a commodity, so it could never be bought or sold. These are the meanings people took with them when they were forced from their ancient homelands onto new places. Therefore, we would like to begin by acknowledging the Indigenous people of the lands that we are on today. While we meet on a virtual platform, we would like to take a moment to acknowledge the importance of the lands which each of us call home. We do this to reaffirm our commitment and responsibility in improving between nations and improving our own understanding of local Indigenous people and their cultures. From coast to coast to coast, we acknowledge the ancestral and unceded territory of the Inuit, Métis, First Nation peoples that call this land home.
Thank you, Colleen. We have the participants in the panel today have no disclosures with respect to the content of the presentation. The objectives today are to discuss the diagnoses of coronary artery disease, stroke, valvular heart disease, and heart failure, specifically in women. To explain pharmacologic and non-pharmacologic treatment strategies for coronary artery disease, stroke, valvular heart disease, and heart failure in women, and to describe the benefits and barriers to self-management and cardiovascular rehab and secondary prevention programs, specifically as they relate to women. I'd like to just say a few words about the Canadian Women's Heart Health Alliance first. This is a volunteer group of healthcare professionals and patient advocates who work together across Canada to improve women's cardiovascular health across the lifespan of a woman. Our mission is to support clinicians, scientists, patients, and decision makers in working collaboratively to implement evidence, transforming clinical practices, and impacting public policy related to women's cardiovascular health. In order to get this done, that's a really tall order. And in order to get this done, we have a wonderful group. We have over 100 volunteers now who work in this organization. And we formed ourselves into working groups. As you can see there, we have the advocacy working group, which is primarily responsible for the Wear Red Canada event that we have on February 13th. And I hope most of you participated and will share that information and participate again next year. Training and Education Working Group, which has been key to develop methods and means to enhance education and training about specific cardiovascular issues that affect women particularly. Projects have included the development of unique teaching modules, which are suitable for the general public, physicians and nurses and students and allied health staff. And you can access all of this at the website, the Canadian Women's Heart Health Alliance website. The Knowledge and Translation Mobilization Working Group this is really the work that we're presenting today, has come out of the efforts from that group, where we have put together a scan of what the current status is of cardiovascular disease in women. This resulted in a document. And then we had so much information that we developed this atlas to be able to take a deeper dive. And Colleen will talk more about this next. And then finally, the Health Systems and Policy Working Group works very closely with the Knowledge Translation Mobilization Group to translate the information we have into exploring cost-effective strategies in improving and monitoring women's cardiovascular health, and to be able to actually work with charitable, institutional, and governmental agencies to make changes. So I'm going to call on my co-moderator, Dr. Colleen Norris, to review some important definitions relevant to our discussion today. Colleen?
Thanks, Sharon. So we will be referring to sex and gender. And for sex, it is biological construct that's assigned at birth, and it's referred to as male or female typically. And it's really what your chromosomes are. It encompasses hormones, genes, anatomy, physiology, and the like. Gender, on the other hand, is a social construct that's socially influenced, and it's referred to as man, woman, or other. It's culturally specific and temporal, and includes things like gender roles and gender relations and gender identity. Next slide, please. We created the Canadian Women's Heart Health Atlas based on the deep dive of the State of the Science paper publication that was in CWHHA originally. There are 9 unique chapters, and they're all being published in CJC Open with the incredible assistance of Dr. Michelle Graham, who was the editor, who was involved in all of our work from the beginning. We started publication in April of 2020, and we are just finishing up chapter 7 now. And our plan is to have annual chapter updates as well, to keep this as a living, breathing document. But they're all on CJC Open website in a curated section for anyone to see, and available for anyone that wants to read them. And so we are going to be talking about chapter 6, as you know, today.
Thank you, Colleen. So let's get into it. And we're going to start off today with one of our patient advocates' stories. Ms. Catherine Goodenough is kindly with us today. We really appreciate her presence here, and it does give me great pleasure to introduce her. She is a retired nurse who is certified in gastroenterology nursing in Canada, and she's a member of our advocacy working group, and she's becoming very active in Twitter, and she is one of our very active members. She is a woman with lived experience, and she's from Mississauga, Ontario, and I'm going to ask Catherine to share her story with us now, and we thank her very much for being with us today.
Thank you for the introduction. My name's Catherine Goodenough, and I have microvascular coronary disease. This is the first time I have ever shared the entire story in front of a group, so bear with me. The previous years before my cardiac event were busy, sometimes stressful. I enjoyed cycling, walking when I had time, and dragon boat weekly practices. But the previous year, I'd noticed that I had a decline in exercise intolerance and shortness of breath. On Tuesday, May 16th, 2017, while grocery shopping, I developed chest pain or chest discomfort, which got worse, moving into my back, shoulders, left arm, jaw, nausea, and shortness of breath. I'd had the 2 episodes a week prior, but not as bad. My husband drove me to the local hospital, Emerge, and where they had specialties in cardiac. I went through the usual blood work, chest x-rays, ECGs. I was told nothing was wrong and sent home. But they have a testing program that they do when anybody comes in with chest pain. So it's called a DART program, which is direct accelerated response team. So I went through a stress test, nuclear stress test, echocardiogram, and an angiogram. That was all done within 3 weeks of being in emerge. I had 4 different cardiologists, one at each test, and I was told nothing. But I remembered a cardiac nurse practitioner pre-angiograms telling me, don't be surprised, we don't usually find anything wrong when we do the angiogram. But upon requesting my test results and consult notes, I found that there was something showed up on my initial ECG. And upon the stress test, I had ischemia, a 2 millimeter ST depression. I also, with the angiogram, I also had a 30% tortuous stenosis in the mid lateral anterior descending artery, which I was told was normal. Due to the shortness of breath, I went on to have some lung tests, and I was told and saw a specialist, and I was told nothing was wrong. I remained active as possible, but continued having chest pains. I documented it all the time, and I kept telling myself, nothing's wrong. It's all been tested out. I remember there was 2 episodes I had in December 2017 that one I woke from sleep with chest pain, and another time I got up to pee in the night. The house was cold, and it triggered the chest pain. So I just went back to bed, crawled into bed, put the covers over my head and cried. But nobody's listening to me. Then in January, February 2018, follow up with a family doctor several times, and she mentioned the words small vessel disease, microvascular disease, but she was going to do some further investigating, which she did, and came up with a few little medications to give me, and then sent referrals to downtown Toronto. While waiting for these appointments, I checked into Dr. Google, and there was not a lot of information, but I found a couple of Facebook groups, which was the Heart Whisperers and Cohorts, which is out of the States, and microvascular angina coronary artery disease, or spasms, which is out of the UK, and I became a member of both groups. They're both private groups. I also read several books, Saving Women's Heart by Martha Galati, and also, Living with Heart Disease by Carolyn Thomas. Carolyn Thomas also had a Heart Sisters blog, which he sent out weekly, which is a good information as well. On the first cardiac consult was at downtown at St. Mike's. The doctor said it was a female I was sent to, and I was reassured that she didn't think it was a cardiac issue. They thought it was GI. And she sent me home with a prescription, which I did not fill because I'd had GI symptoms before, but this was a lot different. Also, she'd said that there was, with regards to the microvascular dysfunction, that often it's overdiagnosed, especially in women. The second consult was also at downtown Toronto. I had it at Mount Sinai, and it's also with a female. And this cardiologist had looked after my dad for over 20 years. So she just did a few further investigating of a 2-week Holter monitor, which showed that there was some ST segment depressions when I had the chest x-ray. But because of having the angiogram showed nothing, she felt there was nothing going on. She also did a carotid Doppler, and there was no significant stenosis, but there was plaque because I had some carotid breeds. There again, I was told nothing was wrong and follow up with your family doctor. But I called them back because I had gone grocery shopping and I had chest pain for over half an hour while grocery shopping, and which was triggered by cold, which was when I opened up the freezer door in the freezer section while wearing the Holter monitor. So from that, they decided to refer me to another doctor who had trained at Mount Sinai, and it was a male. So she sent it to him for further investigation and management because she was not sure what to suggest for me. So I saw him in September 2018, and his name's I've got permission to say it, Dr. Miner, and his nurse practitioner is Mary. They're in South Lake Hospital in Newmarket. He's an interventional cardiologist who specializes in microvascular coronary disease. At the time, he's the only one in Canada. There might be some more, plus he runs a clinic. They also do research studies. I was sent on some further testing. So, a sleep study. So I had sleep apnea, which is mild. They thought because of the breathing, I went for a stress echocardiogram to rule out stress-induced pulmonary hypertension. The result was borderline. In January 2019, I went back to Mount Sinai and had a right heart catheterization and exercise challenge in their breathing program. They said that I found the exercise hard, but I did not reach my cardiac maximum. In February 2017 at South Lake, I had the provocative angiogram, which they administer 3 different drugs. Well, they administered the adenosine, which showed up the microvascular coronary disease. They went on to administer the acetylcholine. I flipped into AFib, and I was the first patient to ever have this happen. So I had the amiodarone in the recovery room and also in the procedure room. And I eventually flipped into back to my own rhythm. I hugged the nursing staff when I was discharged because I'd finally had a diagnosis. Doctor gave me a cocktail of medicines, but due to the AFib episode, I was had another 2-week Holter monitor, which resulted in the same ST depressions because of the ischemia. But I went home and I was not given any cardiac rehab. I continue with yearly checkups at South Lake, Newmarket. Checkups involve stress tests, consult with a nurse practitioner and doctor. I'm still a unique patient, adding different medications to my cocktail every year. I still take nitro as needed, but I document when it's being taken. I usually sometimes take it pre, during, or post activities. In September 2019, I virtually attended the INOCA International first conference they had called Meeting of the Minds. It's in the UK. I also have learned a lot, continue to learn through their Facebook, podcast, and website. In 2019, I discovered I had glaucoma. They said it was due to microvascular, but I take nightly eye drops, and I have treatment and testing and consults every 6 months. In 2019, I was invited to join the Canadian Women's with Medical Heart Issues Facebook group. And then I was also joined the International Heart Spasms Alliance Facebook group and website, which they educate, inform, and enlighten. In 2021, I attended the Women's Heart Health Summit virtually in February 2021, as well as the Wear Red Canada. After many discussions with fellow heart sisters, I decided to become involved. I became a member of the Canadian Women's Heart Health Alliance, the advocacy group. I've been involved in the peer support projects, one being the Peer Support Heart Hub, the other one being Peer Support Review Project, also the Cardiac Rehab Group, Wear Red, and the Jump In Challenge. I also became involved in several research groups as a woman with lived experience. I also took on an expressive writing workshop, Writing the Heart, through the Ted Rogers Center at TGH. I journal daily. I joined Twitter in 2022. I joined Twitter and I took the CWHHA Community Advocacy course. In the winter of 21-22, I decided to embrace winter. Cold is a trigger. I took up snowshoeing. And this summer, I also took up paddleboard. It's still a work in progress, but harder than it looks, balance and core. I continue to walk daily with the Nordic poles, approximately 6 kilometers, 5 days a week. Family, please include family in your journey. They are a part of the story. Speaking from experience, my husband has had 2 heart attacks before my heart stuff happened. Family conversations are important. Listen, be aware of behaviors. They are scared too. Thank you for listening to my story. Keep advocating for yourself. Keep a file of all consult notes and test results. It is your body. You're the only one who knows if something does not feel right. Ask questions, keep learning. Do not be afraid to reach out for guidance, someone to talk to, vent. We are heart sisters, support friends. supportive friends. Every day is a new day. Embrace it. Life is a journey. Thank you.
Wow. Thank you, Catherine. Thank you very much for being a wonderful patient advocate and having the courage to share your story. We know that knowledge is best shared through stories, and your story very clearly exemplifies that the diagnosis of coronary artery disease and cardiovascular disease in women can be very, very challenging. It can lead to confusion, isolation, fear of the unknown. You've emphasized the real importance of communication, which is often also disappointingly challenging, especially with our healthcare providers in the current healthcare system that we have. Seeking peer support can be very helpful, and the books you mentioned are excellent. Social media is also another option for recognized, validated groups, and you have clearly identified some of those. But moreover, advocating for yourself with the support of a group, growing awareness in the community. And I must do a shout out to the Canadian Women's Heart Health Alliance, because really a large part of these efforts have congealed with their direction. It's really essential to helping our women with cardiovascular disease and their challenging diagnosis. You offered numerous practical approaches to advocating for yourself. And I think that our women with lived experience who are attending this session will benefit greatly, and your reach is going to be very, very far. And I thank you very much again for your excellent sharing. Now we'd like to introduce Dr. Monica Perry, who will be presenting a summary of the information in Chapter 6. Monica is an associate professor at the Lawrence S. Bloomberg Faculty of Nursing in the University of Toronto. She is a nurse practitioner in cardiac surgery, but moreover, she is a lifelong clinician educator and researcher. It gives me great pleasure to introduce Monica. Take it away.
Thank you, Sharon. And wow, Kathy, thanks for that lovely story and for sharing the numerous resources to women who are experiencing heart disease or chest pains. I want to thank also Sharon and Colleen and all members of the Canadian Women's Heart Health Alliance who assisted in formulating the Atlas chapter on the epidemiology, diagnosis, and management of cardiovascular disease in women. In the past, this would have been produced as one large hardcover book, but thanks to the Canadian Journal of Cardiology Open, as Colleen mentioned, each chapter has been made available as an open access publication. This means that each chapter is freely available online to researchers, clinicians, policymakers, and importantly, patient partners. Catherine and I have the honor of discussing Chapter 6, Sex and Gender Specific Diagnoses and Treatments. Next slide, please. So cardiovascular disease is a leading cause of deaths for women. And in 2019, it was responsible for 35% of total deaths in women. Generally, age-standardized cardiovascular disease mortality has declined globally. However, since 2017, cardiovascular disease mortality has increased in women in 2 high-income countries, and they include Canada and the US. Additional alarming trends include the rise in heart attacks in younger women. These data present an important call to action for all of us. Represented in this particular figure are the age-standardized CVD deaths per 100,000 women along the y-axis here, and the global burden of disease regions along the x-axis here. Ischemic heart disease was a primary cause of cardiovascular disease mortality in women worldwide in 2019. And Lisa, if you hit the advance button, you'll see an arrow. So this is represented by the dark blue, and this was followed by stroke. So we need initiatives to expand prevention, diagnosis, and treatment of cardiovascular disease in women. And thus we present Chapter 6, which is really focusing on the diagnosis and treatment. Next slide, please. Oh, sorry. So each Atlas chapter has a summary figure, and chapter 6's summary figure is presented on this particular slide. I won't go through the details, but would urge you to find the chapter on the homepage of CJC Open. Generally, we focused in chapter 6 on CAD, coronary artery disease, and cerebrovascular disease or stroke, which I just mentioned were the two most common causes of cardiovascular disease mortality in women in 2019. Also included in this particular chapter is a focus on valvular heart disease, heart failure, and on the bottom right corner, we talk about cardiovascular rehabilitation or secondary prevention programs after an acute cardiovascular event. And more details will come in this particular presentation. Next slide, please. So we've already discussed that ischemic heart disease is the primary cause of cardiovascular disease mortality in women worldwide. Distinguishing between serious and benign causes of chest pain is crucial. And I think, Catherine, your story nicely highlighted this for the audience. Chest pain is reported to be the most common presenting symptom in 91% of men and 92% of women diagnosed with acute coronary syndrome. This particular figure has been taken from the recent chest pain guidelines, and I think nicely highlighted as chest pains. And I'll just go through this very quickly. So chest, the C, chest pains means more than pains in the chest. Women are more likely than men to report accompanying symptoms such as nausea, unusual fatigue, indigestion, dizziness, and palpitation. H represents high sensitive troponins, which is the preferred standard for establishing a biomarker diagnosis of a heart attack. E is early care for acute symptoms in the emergency department by calling 911. This is absolutely essential to rule out other life-threatening causes of chest pain. And Colleen mentioned gender. There are gendered reasons why women delay visiting the emergency room. So that it's important to be seen in the emergency department. S is shared decision-making between the woman with experiencing the chest pain and the healthcare provider. T is testing is not needed routinely for low-risk patients, and I'll get into that in a bit more detail in a few slides. P on the bottom is pathways or clinical decision pathways for chest pain in the ED and in outpatient settings, and there is encouragement to use these pathways more routinely. A, chest pain is a dominant, most frequent symptom, as I mentioned, for both men and women, but women are more likely to have other accompanying symptoms. I, identify patients most likely to benefit from further testing, especially those patients at intermediate or intermediate to high risk, pre-test risk. And I think, Catherine, you are a really good example for us in this regard. So N, non-cardiac, cardiac, and possibly cardiac is in, and atypical or anginal symptoms is out. So we need to really focus on our changing of our terminology. S, structured risk assessment should be used in all instances when women present with chest pain. Next slide, please. So our first key message, women who present with acute chest pain are at risk for underdiagnosis and potential cardiac causes should always be considered. In women presenting with chest pain, it's recommended to obtain a history that encompasses accompanying symptoms that are more common in women with acute coronary syndrome. And I mentioned some of these already: unusual weakness or fatigue, back, shoulder, right arm pain, sleep disturbances, etc. A focused cardiovascular exam is absolutely essential to rule out other causes of chest pain, such as a PE or aortic malformations, and an ECG should be obtained and reviewed within 10 minutes of the arrival to the emergency department. And cardiac troponin should be measured as soon as possible after presentation, and consider sex-specific high high sensitivity cardiac troponins, although there is emerging evidence on these. Next slide, please. It's also essential to weigh in and get a cardiac consultation early on in the emergency room. So recommendations for acute pain, acute chest pain. In patients with chest pain in which the initial ECG is non-diagnostic, serial ECGs to detect potential ischemic changes should be performed, especially when clinical suspicion of ACS is high, symptoms are persistent, or the clinical condition deteriorates. If the initial ECG is consistent with ACS, then treat according to the ST elevated MI and the non-ST elevated ACS guidelines. If there is an intermediate to high clinical suspicion for acute coronary syndrome, when the initial ECG is non-diagnostic, other serial ECGs may be necessary. I won't go into more details here, but I will talk a little bit about some of these on the next slides. So next slide, please. So other cardiac testing considerations. This, we have a variety of imaging and diagnostic tests, and patients with acute chest pain and suspected ACS cover a spectrum of disease, likelihood, and stratification into low versus intermediate or high-risk groups once an ST elevated MI or a non-ST elevated ACS has been excluded. The stratification really is important to guide subsequent management for women. The other important part here is that it reduces unnecessary testing in asymptomatic women and low-risk women in the emergency department, and may offer outpatient testing for women through coronary artery screening or scanning as an outpatient. So this directly comes from the chest pain guidelines and focuses on the high risk and intermediate risk women who may benefit from further anatomic or functional testing. And Catherine, I think you highlighted this as well in your story. If I counted correctly, you had 4 diagnostics, including an angiogram, and you did speak clearly about your stress test and your angiogram results. So thanks again for sharing that. I think it nicely highlights what we see on this particular screen. Testing choices is sometimes dependent on site expertise and availability of diagnostics. And that's all I'll say about this. Certainly further details are included in Chapter 6 and in the recent chest pain guidelines. So next slide. So evidence does suggest that we have an underappreciation of acute coronary syndrome in women. And this is based on, some of our additional symptoms, ECGs, and the biomarkers. And this results in some sex and gender-based differences in referral to have coronary angiography in the setting of acute coronary syndrome for women. Coronary angiography is the gold standard test for the diagnosis of obstructive coronary artery disease. It really defines the presence and severity of obstructive disease and the feasibility and necessity of percutaneous or surgical intervention. Protocol diagnosis of ST elevated MI recommends prompt referral for cardiac cath for PCI or percutaneous coronary interventions in women. In women presenting with non-ST elevated MI with high-risk features such as a positive troponin, early invasive stratification again is necessary by using coronary angiography. Other additional non-invasive diagnostic testing examples are really included on this particular slide. These include exercise ECG for women that are able to exercise greater than 5 METs, stress, nuclear PET or SPECT scans, echocardiography, cardiovascular magnetic imaging, and coronary computed tomography angiography. And these should follow a clinical decision pathway and really be based on previous, ECGs, troponins, et cetera. And again, that's, I won't highlight any more here, but it is important to get an adequate history and perform an adequate cardiovascular exam on women's to really stratify them and seek coronary angiography as that gold standard for those women if needed. So next slide, please. So key message number 3, and I think I've just shown this, or we've shown this on this previous slide, various non-invasive imaging strategies are used for stable or non-acute presentations of chest pain. The exercise treadmill test is rapid, inexpensive, and the most common non-invasive test for low-risk women who can exercise. There is improved diagnostics and prognostic evaluations if you can integrate other multiple parameters such as exercise time or changes in ST segment or presence of angina, or looking at other risk correlates such as heart rate and blood pressure responses and recovery during the test. There are, however, contraindications for an exercise stress test, and we've indicated those on this particular slide. So this stress test is still recommended as an outpatient for women. So next slide, please. So what is the correct diagnostic test? There are many tests available. The purpose of this presentation is not to go through what is the correct diagnostic test, but just give you a flavor of the complexity in choosing the diagnostic test based on that early assessment of the woman. So really looking at that pretest likelihood of coronary artery disease. If there is low risk, really no further testing in the ED is necessary, but you may opt for coronary artery calcium scanning as an outpatient setting for further risk stratification. If the woman is at intermediate to high risk and young, and you suspect non-obstructive or less obstructive CAD, then perhaps a CCTA is favored. If the woman is of intermittent to high risk and older, and you suspect more obstructive CAD, then perhaps a stress test is favored. So it is complex, and engaging sort of the experts in terms of cardiology would be important. So next slide, please. So key message number 4, recommendations for the pharmacologic management of women with stable CAD. In the green is strong with high quality evidence, and red represents the conditional with moderate quality evidence. So the use of aspirin acutely at the time of acute coronary syndrome and for secondary prevention is a benefit in both sexes. Indeed, the long-term benefits of aspirin, beta blockers, ACE inhibitors, and statins after an MI are beneficial for both men and women. And they have been shown to reduce major adverse cardiac events in both sexes. Despite the benefits, though, women with both obstructive and non-obstructive CAD continue to be underprescribed ASA, beta blockers, calcium channel blockers, and ACE inhibitors. Sex differences in the administration and effects of statins are under constant debate, it seems. There is some evidence to suggest that more women develop diabetes with statins. Statins also have a pregnancy category X, which means that they shouldn't be used in pregnancy. Studies have also shown that women may be more sensitive to ACE inhibitors or more intolerant to ACE inhibitors and more sensitive to ARBs, meaning that perhaps we need lower doses of these agents versus not being prescribed ACE inhibitors and ARBs. Similar to statins, ACE inhibitors and ARBs have pregnancy contraindications that you should be aware of. Again, I'm not going to highlight that as we publish that in previous chapters of our atlas. So just wanted to highlight a little bit about the pharmacologic management of women with stable CAD. So next slide. If we look at the non-pharm management of women with stable CAD, coronary artery bypass graft surgery is considered the gold standard for revascularization for multi-vessel CAD with diabetes that's non-amenable to PCI. And this would be for obstructive CAD. However, the recent ischemia trial failed to show that routine invasive therapy actually reduced major adverse cardiac events compared to optical medical therapy. And their sample size included 23% females. So I think there'll be a bit of a debate and maybe a shift in the future and something to keep an eye on. Next slide, please. So stroke affects women across their life course, although the risks are higher during pregnancy, menopause, and later in life. Stroke can also present with non-traditional symptoms in women that may be misinterpreted or interpreted as being less significant. For example, tingling, numbness, short duration visual, speech disturbances, fatigue, nausea, and vomiting. The interpretation can delay stroke recognition and lead to a bit misdiagnosis. Once stroke is recognized, however, the approach to diagnostic imaging among women and men is similar, and that's usually with a non-contrast CT. So next slide, please. So key message number 5, stroke affects women across their life course. Risks are highest during pregnancy, menopause, and later years. So it's important to recognize the non-traditional symptoms of tingling, numbness, visual and speech disturbances in women for prompt diagnosis and referral for prompt diagnostics. Next slide, please. Heart failure. Heart failure is the second leading CVD-related cause of hospitalization and third leading CVD-related cause of death among Canadian women. Women with heart failure often demonstrate greater symptom burden than men, including more shortness of breath and poor quality of life. Women with heart failure are often underdiagnosed and undertreated and experience delays in referral for health services and invasive care. This difference is partly related to sex differences in the etiology of heart failure. For example, more women, and you can see on this slide, have heart failure with preserved ejection fraction, which means that women have, their hearts are too stiff and it makes it difficult for their heart to fill with blood. Next slide, please. So not going into too much detail here, the figure on the right does differentiate between the types of heart failure. You will note that in chapter 6, we discuss heart failure in terms of acute and stable presentations. There is a lot more about heart failure in previous chapters of our atlas, but in the context of acute heart failure presentations, NT-proBNP levels, which is a type of blood work, appear to differ by sex, increase with age, and vary by heart failure phenotype. For example, it is generally lower in women who have heart failure with preserved ejection fraction compared to women who may have heart failure with reduced ejection fraction. However, at this time, NT-proBNP sex-specific cutoffs are not recommended, but we may see this shift in the future. Next slide, please. So again, in terms of acute presentations of heart failure, women are less commonly discharged on ACE inhibitors and mineral corticoid receptor antagonists, or MRAs, despite having similar length of stays in the hospital. Women are also more likely to receive digoxin, which has not been demonstrated to provide mortality benefit in heart failure with reduced ejection fraction. In terms of non-pharm therapies for women, women are underrepresented in cardiac implantable electronic device studies. So this means that we really don't have evidence to suggest they're better or useful in women. And these include studies that look at pacemakers, ICDs, and CRT devices. Next slide, please. Key message number 6, women with heart failure report lower quality of life than men. Women less frequently receive ACE inhibitors and MRAs compared to men, and we're generally underrepresented in clinical trials, and current guidelines are lacking on sex-specific recommendations. Next slide, please. Just a brief mention here about valvular heart disease because it is included in chapter 6. Very few studies report on valvular heart disease sex differences. In essence, what this graph shows, and this was taken from a paper which is referenced here, and Marie-Annick Clavel is a co-author on chapter 6 as well. This graph basically shows that women have similar benefits to surgery post, and this is specific to mitral valve surgery, in terms of reverse remodeling. So sort of their heart sort of going back into shape with similar effects on survival as men. There are differences though in terms of referring women for surgery. Women are generally under-referred, and this in part is related to some of the diagnostics and the imaging results that we receive. So when women are referred, they're usually a little sicker and end up with a little bit more heart failure post-surgery. The last point here that we highlighted in chapter 6 is that if we're looking at the aortic valve and aortic stenosis, transcatheter AVR or aortic valve replacement seems to be preferred over surgical aortic valve replacement in women. Next slide, please. And women are 50% less likely than men to participate in cardiac rehabilitation. We included a wonderful quote from Marcia Hardy, who is another woman with lived experience on our team and a member of the Canadian Women's Heart Health Alliance. And I'll just tell you that recently the International Council of Cardiovascular Prevention and Rehab developed clinical practice guidelines to provide guidance to the rehab community on how to deliver effective women-focused programming. I think only about 5% of the cardiac rehab programs in Canada are women-centric, and they do have 15 key recommendations, which I think will help improve attendance for women in the future. So next slide is our summary slide. CVD is a leading cause of death in women. Since 2017, CV mortality has increased in Canada. Younger women are having heart attacks, and more women have non-obstructive CAD. Stroke affects women across the life course. Current guidelines have limited sex-specific recommendations, and all women should be referred for CV rehab or cardiovascular rehab and secondary prevention. So thanks for your attention.
Thank you, Monica. That was just an extraordinary summary of a huge amount of information. And I really think you did a very clear and succinct focus, particularly bringing the focus onto women with a laser light. So we encourage you to ask your questions in the chat box, or in the question box rather, and I see that we have one, which is great. And while we're getting to that question, we actually have a few questions for you that I neglected to ask at the beginning of the session. And that is, if you could please address the poll at the current time. Who is in the audience today? Are you a patient or former patient, caregiver or family member, healthcare provider or researcher, trainee or other? If you could take a moment and just fill that out for us, please. Great. So we have a lot of patients today, or former patients, over half of you. Thank you for being here. Healthcare providers, about a third, researchers and trainees make up the others. We have one more question. If you could show that question as well, please, Melissa. As either a woman who has experienced chest pain or a healthcare provider who sees women with chest pain, I have found it challenging to establish the cause. And if you could pick one of the three options there, yes, no, or not applicable. Right, it's tough. I think that we all agree. There are maybe a couple of you that feel very expert and your diagnosis was very readily achieved. So that's great. But I think that it does underscore the challenge that we see. And I'm going to maybe get to the first question here, and then I'm going to turn it over to my co-chair, Colleen, to come up with some other questions. I know that she has a couple of burning ones, but Sheila Garapi, thank you for your question. How is the level of risk defined in determining whether or what testing is appropriate? Monica, did you want to address that first?
I'm happy to let you address that.
I'm happy to do that. I just wondered whether you had a stab at it there. So I think it really depends on what clinical setting we're in. If it's acute chest pain versus if it's a chronic, stable, what we call stable coronary disease. So chest pain that hasn't brought you to the emergency room, but that you're noticing and that needs to have an evaluation. So in the acute chest pain situation, it is key, as Monica went over, that every individual that presents to the emergency room with acute chest pain needs to have a troponin level done, an electrocardiogram done, and that's while an excellent history and physical is being taken. And then this clinical information together is put to make or refute the diagnosis of an acute coronary syndrome. And so low risk patient in that acute setting would be an individual who was having a low troponin level, so a zero troponin level effectively, or no electrocardiographic changes, or a history and physical that did not suggest that this was cardiac in nature. In contrast, in the chronic patient, sorry, not chronic patient, but chronic symptoms. So the outpatient, you've noticed chest pain, it's concerning. Should this be evaluated? There we do a risk assessment as well. And there are several tools that we use to, they're official tool scoring mechanisms that have been validated by large patient populations, taking into account age, gender, duration of symptoms, as well as known cardiovascular risks, which we've talked about in our other chapters in great detail. Smoking, diabetes, hypertension, obesity, inactivity, and the high cholesterol, and as well sex-specific risk factors, which would be a history of preeclampsia or a history of being postmenopausal or gestational diabetes, preterm birth, et cetera. So it really does depend on the setting. I hope, Sheila, that I have clarified your answer, the answer to your question, but I would refer you to the chest pain guidelines document, which Dr. Martha Galati is the lead author, and we have put that there in the chat box because that goes over all of the specific risk scoring mechanisms that have been validated and are in the literature published, so that you will have access to those there and all that detail. Thank you. Did you have anything to add there, Colleen?
No, that was really thorough, and I'm starting to look at the questions, and I want to address all of these things. It's, when you mentioned about having questions, I think Kathy's story, it's so reflective of virtually every woman that has some level of heart disease. And I think we keep referring to the idea of chest pain, and Martha Galati says, or chest pain equivalents. And Sharon, this started me on looking at just what are we doing in emergency departments, because if you don't say the word chest pain as a woman, I have a real discomfort, and women from a gender perspective always downplay what their symptoms are, or I have this left side of my arm is killing me. If you don't say the word chest pain in the emergency department, then you will not, at this point in time. We polled all the hospitals across Canada, and they don't have anything other than a chest pain protocol. And the way you get into that chest pain protocol is you say, I have chest pain, and they will start to follow you up for heart disease. And this is unique to women. And Kathy mentioned it. Like, it's so frustrating to me that you have to keep, we say you need to be a strong advocate for yourself. But on the other hand, we need health service providers to start recognizing this is a female standing in front of me, and this is what I have to rule out, right away. And I know we keep saying you need to be good advocates for yourself, but we also, there's so much work that needs to be done on our side. It's just my big comment. Listening to Kathy's story, it's so desperately sad because it's not unique, and that's crazy that it would take 2.5 years to get a diagnosis, or to get some answers to what's going on.
Yeah, and that's not unusual, is it? So I think that's a very well taken point. Chest pain is kind of it's a label, and it's an old label, but it's one that the medical community understands and knows how to deal with. So actually, we've even counseled some of our patients who, may be having symptoms that are certainly unusual and difficult to describe, but may not describe it as a pain. It's a discomfort, a tightness, whatever, but just to translate that into saying pain, because then that, as you said, triggers protocols which are established to be able to get into that diagnostic algorithm. And sometimes it doesn't happen otherwise. The associated symptoms that women also have or can have instead of chest symptoms are also becoming more recognized. And that's one of our key messages that we were sharing with the Canadian Women's Heart Health Awareness Day as well, in the campaign there. So I would urge you to become familiar with those. And we are there's big efforts to be educating our healthcare providers that are at the first point of contact, particularly in emergency rooms, and also family doctors, to be able to understand that it can be somewhat of a chameleon in the way that cardiovascular disease presents in women. Exactly. There are some specific questions here. And actually, before we leave that topic, though, of chest discomfort, Kathy, did you have any insights that you would like to share as a patient going through this system with symptoms, and to try to get finally an established diagnosis and to get treatment that would be able to be not only symptom relieving, but also prognostically, that means life prolonging, very beneficial?
I just kept advocating for myself, that I knew my body, that I knew something was wrong, and I just had to keep pushing to get it diagnosed. As I said, just documenting when you have the chest pain, because it could be, in my case, microvascular can be when you're at rest, or it could be when you're just sitting in a chair, or when you're exercising or doing something like gardening or whatever. So just documenting it all is a benefit. So at least you have something to go to the doctor and show what's going on. As you say, calling it a different name, but as women, we don't always go the first time it happens. We put it off. There's other things to do in life.
That's another very much gender-related issue, cardiovascular disease in women. That's absolutely right. And there's been quite a few studies on that, actually. And that is the topic of our next chapter that will be coming out, chapter 7, about the social determinants of health and how that impacts on the gender-specific aspects of cardiovascular disease manifestation in women in particular. So yeah, very, very good points, Kathy. And thank you. You gave an excellent list of resources that you found too. And I do think that, because this is becoming, more aware in the medical community that, women can have microvascular disease, for example, in your coronary microvascular dysfunction, that awareness is definitely increasing. And so validation of that diagnosis is still difficult because not many centers actually do the coronary invasive physiology testing. But sometimes it's okay. We can at least use a strong clinical assumption and then treat accordingly. So if you don't find someone basically that is listening to when you know that there's something wrong with going on in your body, then keep looking. And there are a lot of resources out there. And I think that your pathway is very good, that it had a positive ending or positive outcome with respect to you being actually able to have help. Colleen, did you select another question here from the audience? We have about 2 minutes left.
Yeah, I just think we need, Laura Little has commented that the last week she's been passing out, she's exactly the same symptoms as Kathy for the past year and a half since my right artery was 100% blocked. Last week I've been passing out, sent to the hospital by ambulance, and they sent me home to follow up with a family doctor. And then I feel like I'm going to die before I can get any help. And that's just not something that we would ever want to happen in our Canadian healthcare system. And Sharon, you know, like, how do we get someone to listen here?
So, you know, if that's the case, Laura, like that is a serious issue, and you need to make sure that you be persistent and get the appropriate assessment and diagnosis for what is going on. As we said, we can't really address personal symptoms here in this forum, but this is very concerning. And if you don't get satisfaction, then go to have the ambulance take you to another emergency room, or, you know, find another physician, or, you know, you need to have a diagnosis. So I would encourage you to be, unfortunately, it's really on your shoulders, I guess, in your situation right now, but to be a strong advocate for yourself and to reach out to find the assistance that you need, because that's very concerning.
Very, yeah. And it kind of reminds me, not to make light of it, but I remember when I was pregnant, having a baby, and the student nurse came in with Demerol, and I asked, how much do they have? How much Demerol do you have? And she said whatever it was. And I said, don't come back in here until you have more Demerol. And I think we need to actually do this sort of thing. Like, say, I will not leave. We're going to send you home. No, I'm not going home. I need an answer. I'm not going home to follow this up. Like, it's really tough to be like that, because you want people to like you. That's the bottom line. That you don't want to be the bad patient, but that's the only way we can get answers, and say, I will not leave here until somebody tells me why I passed out.
Well, part of that is gendered as well. Women don't want to bother people, and we need to sort of get over that, right?
Yeah.
Yeah.
There are a couple of other really good questions in the Q&A. I'm not sure that we're a bit over time here, so I'm not sure we actually have time, but I think that we have good resources. And so Mary, you've asked specifically about SCAD, MI, and we did address that somewhat in the paper. So if you would go in detail there, as well as there are excellent resources available. And I know that you are very proactive about this, and you're very active on Twitter as well. So that there are lots of resources. Sharon Hayes, the Mayo Group, has put together a lot of information. And then here in Canada, Jackie Saw at UBC. So there obviously are challenges, because a lot of women with SCAD are younger, and if they are on dual antiplatelet therapy, then yes, that's a bleeding risk, that's a problem. But there is actually no evidence for prolonged dual antiplatelet therapy in SCAD patients. So, and I discourage that. And at Mayo, we actually never even put them on it acutely. So it really depends on the individual case, of course. If there were things that were seen, if there was an intramural hematoma as well as an extramural hematoma, or sorry, an interluminal hematoma, as well as in the wall of the vessel, maybe there would be a short-term thought of using dual antiplatelet therapy. But in general, we just recommend low-dose baby aspirin, and that is indefinitely. As well, the other important thing in SCAD patients is to control blood pressure. So beta blockers have been recommended, and a lot of these women are young and they can't tolerate beta blockers. So I have found that the best tolerated beta blocker actually is bisoprolol in very, very low doses. And that gives some protection, we think, to the shear stress in the vessel wall to prevent further tears from occurring. And there is some retrospective evidence in Dr. Saw's work with the CAN-SCAD database that beta blockers can prevent recurrence in SCAD. And then there was one other quick question that was medically related here with respect to dosing. Yes, very important. And there are certain categories of medication that are tolerated differently by women, and the dosing is certainly antiplatelet treatment or intervene acutely in the cath lab, if that's the case that that type of therapy is needed. It needs to be weight adjusted for women. And there are other types of medications that need to be adjusted according to weight and the known distributions that are different gender-based. We do address that in this chapter. So if you would go there, there are more details on that particular topic. Finally, MINOCA. Yes, Helen, MINOCA is a challenge. That means MI, or myocardial infarction, without obstructive coronary artery disease. That is a very challenging diagnosis, more common in women, occurring probably about 7% of all heart attacks, I think is the, maybe even a little bit more, is the estimate. And that is really a situation where it is a diagnosis of exclusion. So we have to make sure that there aren't other things going on. And there are some excellent guideline documents actually on that have come from Europeans as well. There's a statement from the Americans. And we have just formed, as part of the Canadian Cardiovascular Society, our own writing group for developing Canadian guidelines that you should see within the next year and a half or so. And I would also suggest that with respect to MINOCA, there is a registry that we are trying to form that we have put a grant application in for to Heart and Stroke. So maybe that will be successful. And so we're actively doing this in our own Canadian environment to be able to explore and be able to make more specific Canadian relative guidelines. And you will see that just posted in the chat box. Melissa has put in there about an upcoming webinar specifically on SCAD on September 20th. And I would suggest that you go to that for more information there. And we'll probably be having one on MINOCA coming up as well too. So thank you very much. I'm so sorry that we are out of time. We're over time. I thank all of you that have stayed with us. Certainly we are open to being able to, contact us and ask questions as well. So did you want to say the closing remarks, Colleen, please?
No, that's, you go ahead.
No, I just wanted to thank again our wonderful speakers. Thank you very much, Kathy, for sharing your story. It was extremely powerful, and I think it leaves us all with many questions, but it also leaves us with hope. And I think we're actually heading in the right direction. And Monica, for reviewing very nicely the data. And the data, there's a lot of research, obviously, that still needs to happen and is ongoing, and that this is a works in progress. And it's wonderful to see so many great minds involved in this, and to see our healthcare providers working hand in hand with our women with lived experience to improve outcomes, cardiovascular outcomes for women going forward. And all this, really, thank you to the Canadian Women's Heart Health Alliance and for providing the structure to enable this to happen. So thank you all very much. And I wish you all well, and please use the resources that have been posted, as well as on the Canadian Women's Heart Health Alliance. You will find a wealth of information to guide you and help you, including peer support options. So thank you very much. Please don't forget to fill out the evaluation.